Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Toda Hiroki. Prof. Hiroki is a clinical professor of neurosurgery in the Kyoto University and the program director of neurosurgery at the Medical Research Institute, Kitano Hospital, Osaka, Japan. He was a former fellow at the Stanford University, followed by Toronto Western Hospital in Canada. And he is also a member of the World Federation of Stereotactic and Functional Neurosurgery and the Japanese Society of Stereotactic Functional Neurosurgery. His clinical interests are focused upon the management of functional disorders and neurovascular conflicts. He is a noted author with several publications in various peer-reviewed journals, and we are extremely honored to have him today at our webinars. And today he will be talking about microvascular decompressions for neurovascular conflict. The speaker for the second session of today is our honorable guest from China, Professor Wu Shuihai. Professor Wu is the Deputy Director of the Shanghai Neurosurgical Emergency Center. He is also a Professor of Neurosurgical Department at the Huashan Hospital, Fudan University, and the Professor of Chinese National Center for Neurological Diseases. His clinical interests are focused on the diagnosis and treatment of severe traumatic brain injuries and complication of disorders of consciousness, especially for hydrocephalus and disorders of consciousness. He proposed a new classification for hydrocephalus according to the pathophysiological characteristics of hydrocephalus to accurately treat hydrocephalus in patients with consciousness disorders. He is leading several randomized controlled multicenter studies on chronic subdural hematomas, anorexal subarachnoid and hemorrhage treatment based on ICP, neuromodulation and disorders of consciousness. We are extremely honored to have him today at our webinars, and today he will be talking about body position therapy for treating raised ICP in chronic subdural hematoma patients. The chair for the first session of today is our distinguished faculty from Germany, Professor Uwe Keller. Prof. Keller is the professor and head of department in the head Neurocenter Spine Center in the Asklepios Clinicum Altona. He was the past president of the Hydrocephalus Society. As a specialist neurosurgeon, Prof. Keller, together with his team, is an expert in the management of cerebral tumors, hydrocephalus, trigeminal neuralgia, brain injuries and cerebral hemorrhages, vascular malformations and compression syndromes of the peripheral nerves. He is an invited faculty to several national and international congresses around the world, and we are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honorable guest from India, Professor Virendra Dio Sinha. Prof. Sinha is the president-elect of the ACNS, and he is the head of Department of Neurosurgery at the Sanktoba Durlabji Memorial Hospital cum Medical Research Institute, Jaipur, India. He was a former head of department of the Savai Mansingh Medical College, Jaipur. And he was the past president of the Skull-Base Society Surgery of India and the president of Neurotrauma Society of India and chairman of Neurorehabilitation and Reconstructive Neurosurgery Committee of the WFNS. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President Prof. Yoko Kato, I would like to welcome both the speakers, chairs and wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Uwe Keller.
Thank you very much. Hello to everybody. And it's a big honor for me to chair this very interesting and exciting webinar. The first topic will be microvascular decompressions. And I really have done a lot on my career. And I must say that with every surgery, it's just a little bit different. I learn something more with every surgery. And so I'm very honored that we have a real expert today about microvascular decompressions here. This is Professor Hiroki Toda from the Kitano Hospital in Osaka. And he will share now his vast experience and probably give us a lot of tips and tricks for microvascular decompression. Please, Professor Hiroki Toda, the microphone is yours.
Okay. Thank you very much for the great opportunity to speak about my expertise on microvascular decompression. I truly appreciate the very kind introduction for the program directors and Professor Yokida, and I also like to thank the Professor Yoko Kato and Professor Gonsang Liu for the kind arrangement of this wonderful webinar. So let me just start my presentation now. So I'm going to speak about the MVD for neurovascular compression disorders. That means the hemifacial spasm, trigeminal neuralgia, and glossopharyngeal neuralgia, as long as the time passes. Okay, so this is a kind of the photo which was held in June, the end of April, I think. And Professor Yoko Kato invited me to this wonderful meeting, and also Professor Bonson Liu invited me to this the great program today. Okay, so I don't have a COI for this presentation. So just let me briefly introduce my hospital, Kitano Hospital. It's going to be 100 years since establishment, and it's located in the downtown area in Osaka. Osaka now holds the expo now, so many people from all over the world. It's going to be a very exciting event now. And this is a neurosurgical services consists of neurology and a neurosurgery department. Our department also has a history about more than 60 years. And this is the list of the operation last year. So our neurological service offers the general neurosurgery, and today's topic, microvascular decompression cases, are almost 15% of all our cases. And the photograph of Professor Akinori Kondo, he is the pioneering surgeon in the field of microvascular decompression in Japan. And the following surgeons, including Dr. Iwasaki and myself and our colleagues, perform microvascular decompression in this hospital regularly. So since 2019, we started to use the OBI. This is which is the exoscope system. And we use this system instead of a binocular microscope. And in the middle of 2020, we changed the patient positioning for microvascular decompression and other CP angle tumors from the lateral recumbent position to the supine or supine lateral position to perform a retrosigmoid approach. And in this presentation, I aim to describe a setup and the steps to perform the exoscopic microvascular decompression, including the patient positioning and exoscope OR layout. And we also present several illustrative cases to highlight the benefits of 3D 4K exoscope imaging. And we also like to discuss the risk and the complication in these cases. So this is a list of our series. We retrospectively reviewed 300 of exoscopic microvascular decompression surgery and also 300 microscope cases. So before 2020, we basically used the microscope, but since then we mainly use the exoscope, and right now we only use the exoscope only. And 60 to 75% of these patients suffered hemifacial spasm, and most of the rest were trigeminal neuralgia. And the number of glossopharyngeal neuralgia patients is about 1/10 of trigeminal neuralgia cases. And as I mentioned earlier, we changed the patient positioning from the lateral recumbent position to supine or supine lateral positioning after introducing the exoscope. So this is the layout, and this scheme shows the exoscope layout. So we place the exoscope system in front of the patient face, and this photo shows the exoscope arm is brought to the surgeon over the patient's head. And the patient's ipsilateral shoulder is elevated, and the head is turned toward the contralateral side. And the neck is flexed slightly, and just considering the intraoperative effects on the venous and the sinus pressure, we can slightly elevate the patient's head to minimize the venous pressure. And placing the exoscope on the opposite side of the surgeon, which helps us use the full range of motion of the exoscope arm joints, and it makes us adjust the camera position very finely. And even a patient with a short neck, the patient's shoulder does not interfere significantly with the surgeon's procedure. So we can place the hand just above the patient's shoulder, and we can do a microvascular decompression surgery. And in addition to this information, we place the monitor around 5 feet from the surgeon to achieve the best 3D effects. So I will show some basic steps for real sigmoid approach. During the approach, we place the exoscope camera above the head to record all surgical steps, such as preserving the left occipital nerve, and also cutting the sternocleidomastoid mastoid and splenius muscles, and dissecting the mastoid emissary vein and coagulate it, and exposing the mastoid notch and coagulated and cut the mastoid emissary veins around the mastoid foramen is exposed, and we continue to skeletonize the mastoid foramen. And we also cut the occipital artery and the stylodiaphragm to expose the inferior nuchal line, which is the main landmark to make a proper craniotomy. And we detach the superior oblique capitis muscle from the inferior nuchal line and exposes the suboccipital surfaces inferiorly and laterally to the edge of the condylar fossa. And we make a ball hole and a small bone flap using a steel bar. And cutter makes a small piece of bone flap. And after this, using a Ronju and a Kearson punch, we expose the inferior sigmoid sinus. And we pack the open the mastoid air cell using a piece of bone wax to minimize the CSF leak. And subsequently, we cut the dura and release the CSF and turning the dura flap and obtain a good trajectory for the cerebromedullary system. So this supine positioning helped us to obtain a good trajectory without with a minimum brain retraction. So let me go ahead to the hemifacial spasm cases. So this is an illustrative case of gravity-assisted cerebral retraction. So we don't need any brain spatula. And after opening the fissure and additional arachnoid cutting, we notice the upper loop, the pica, is a compressed facial nerve root excision. So now we pull out the pica gently and fix this artery to the dural surface using a fibrin glue and confirm the no artery here. But we're afraid near the ICA near the root excision might be the compressing after the CSF returns. So we also mobilize the ICA and fix it on the dural surface. And we also use the sub-monitor system to check the monitoring, such as auditory brainstem reflex. So we can check the function checking this the side monitor by side. And we also use the PTFE sling technique to mobilize the ICA, but in this case, there's a very short segment of the perforating artery, so which limits the mobilization of the ICA. So we use the multiple PTFE fibers to sling the ICA toward the dura, but the perforating artery is very short, so we just adjust the tension of the PTFE fibers, not to kink the ICA. Okay, this case is the left hemifacial spasm caused by a tortuous ICA. So first we dissect the glossopharyngeal nerve from the flocculus, and after then we mobilize the vertebral artery. So after dissection of the arachnoid over the jugular tubercle, we place the vertebral artery and fix it onto the dura using fibrin glue. And we also applied another fibrin glue to mobilize the adjacent vessels. Now we are dissecting the ICA, and we also sometimes dissect the suprafollicular arachnoid to minimize the direct retraction of the auditory nerve. So after then, we try to mobilize the flocculus. So this is the very tiny glossopharyngeal nerve. But so very gently dissect the arachnoid, and now we confirm the ICA compressed the root exit zone. So we mobilized the ICA by cutting these fine arachnoid near the facial nerve and near the brain stem, and keeping the perforating artery intact, and fix it onto the adjacent vertebral artery, and finally confirm the decompression of the root exit zone. And the next case is the tortuous vertebral artery. So both sides of the vertebral artery is involved in the hemifacial spasm. So in this case, we use sorry. In this case, we use several adhering techniques. The first is we use a small piece of cyanoacrylate. So this is the small drop of cyanoacrylate, and attach it at both sides of the vertebra as the single vessels, and compressing the vertebral union downward. And this yellow stuff is the tackle seal and fibrin soaked tackle seal, so it's very adhesive. So it's going to be adhered to the dural surface, and after then we pull out the ICA venous vertebral artery, and once again we use the tackle seal, fibrin soaked tackle seal, and vertebral artery ICA is attached to the vertebral artery. This MRI shows the resolution of hemifacial spasm, resolution of decompression, and the patient is stable, and the decompression stable at least 12 months after the surgery. This is kind of a unique case of the lateral compression. So usually the artery coming from the medial side, but in this case, the artery between the 7th and the 8th nerves cause the compression. So let me show you this compression. So just now we pulled out the ICA between the 7th and the 8th nerves, and this arteries is running between these two nerve bundles. So after dissecting this artery from the lateral side of the facial nerve, and we also notice there's a discoloration and a thinning of the facial nerve, and we mobilize this artery and adhere to this artery to the dural surface. Now, sometimes we notice the cysternal part of the facial nerve is compressed. So cysternal compression cases is 7% in our series, and excellent or good outcome is a less number comparing to the root exit zone cases, but it's a comparable surgical outcome. So after the thorough discussion with the patient family, we may offer the microvascular decompression in these cysternal neurovascular compression cases. Fortunately, so far we don't have any hearing disturbance or facial palsy in this cysternal group. And this is another case of the cysternal compression, and in this case, it's very difficult to completely mobilize this ICA between the 7th and 8th nerve. So we just moved this ICA toward the more distal area to release the more proximal facial nerve compression. So this is the kind of demographic data showing the dominant characteristics in our series. So women and a middle age between 30 to 60 years and left-sided, and ICA or ICA-PICA compression is a dominant characteristics. Vertebral artery involvement is seen about 40%, and 80% of all these patients had excellent outcomes 12 months after the surgery. And from our series, the outcome is significantly different among the compressing artery types. So PICA and ICA-PICA have a little worse outcomes compared to the others. However, our recent modification, the mobilization technique, as seen in this the previous videos, I believe that these modification may improve our outcomes of PICA group to the level comparable to those ICA and PICA groups. And here's a summary of the hemisphere spasm outcomes of vertebral artery associated and non-associated groups. So vertebral artery groups has a comparable or better outcomes, although there's no statistically significant differences between these groups, but vertebral artery group has a good outcome after the surgery. And complications, we have only one hearing loss cases, and otherwise the most cranial nerve deficit at the transient. And we also have one chronic subdural hematoma cases, which one patient needs a irrigation twisted type drainage is needed, and maybe related to the pneumocephalus, which I will discuss later. Okay, so let me move on to the trigeminal neuralgia. So we use to diagnose the trigeminal neuralgia. We use the heavy T2 sequences like a CISSS, Fiesta, or Drive MRI sequences. And if we suspect the venous compressions or artery and a venous compression, we use a contrast enhanced CT scan to confirm the venous structure near the trigeminal nerve. Okay. And the most cases, arterial compression, and 75% superior cerebral artery, follows by ICA and trigeminal cerebral artery, and a few cases the persistent trigeminal artery variance or vertebral basilar artery compression. And probably 7 to 8% patient might have a venous compression, which is a minor but a very important compression pattern. So 75% has SCA, and usually SCA has a circumflex type perforating artery, and those arteries are usually long. So it will not limit the mobilization of the superior cerebellar artery. So it's going to be a sort of easy mobilization, but in some cases, very elongated superior cerebellar artery. So in such cases, we dissect carefully and pull gently and pull, dissect, pull. So repeating these procedures and finally mobilize this elongated artery to the lateral side of the trigeminal nerve. Okay, this is the series of photographs showing the gentle mobilization, and pulling out the SCA to from the medial to the lateral side of the trigeminal nerve. And 10% of patients have ICA compression. And in ICA cases, the perforating artery is short, relatively short, comparing to the SCA. And in this particular case, we have encountered the delayed auditory nerve dysfunction during the decompression procedure. So we just mobilize this ICA from the lateral side of the lateral inferior side of the trigeminal nerve, and we mobilize it, and we try to fix it onto the dural surface. But after this, we noticed the almost a flattening of the brainstem auditory responses. So we released the ICA again, and so after that, the brainstem reflexes also return. So we know we suspect just a slight change of the circulation through the perforating artery might affect the auditory function. So we just adjust just the minimum decompression in this case, and finally the patient was okay to preserve the hearing function. And the 5% patient may have a trigeminal cerebellar artery. So there are the original trigeminal cerebellar artery has several theories, like TCA might come from the basilar artery branch, or it may be a hypoplastic ICA, or it may be a continuation of a superlateral or inferior lateral pontine artery, or it may be a caudal remnant of primitive trigeminal artery. But so we sometimes notice. So in this case, the SCA is shown in the red, and the TCA is shown in the purple. So this the loop of the purple vessel is a TCA. So after cutting the arachnoid sleeve enveloping the superior petrosal vein, we confirm the SCA is compressing the trigeminal nerve from the superior side. So we gently pull out this SCA first, and after mobilization, we confirm the arachnoid between the SCA and the trigeminal nerve. So we cut the arachnoid, this tiny arachnoid, which helps to mobilize the SCA much better. And we pulled out SCA beyond the superior petrosal vein, and we fix it this artery using the fibrin glue again. And this is now opening the horizontal fissure, cutting the arachnoid over the horizontal fissure to confirm the lateral aspect of the trigeminal nerve. And this loop is the TCA, and we notice there's a small perforating artery here. So we decided we just insert the small PTFE fibers and fix it onto the dural surface. One end, and the other end is onto the dural surface in a different the part. And finally, this loop is slinged up, and there's no compression on the trigeminal nerve. And another variant is a primitive trigeminal artery variant. It originated from the precavernous internal carotid artery, and it causes cerebellar artery without interposition of a basilar artery, and it associates with the trigeminal nerve. Sometimes that causes the trigeminal neuralgia. And in this case, we just gently pull out in the lateral direction of this PTAV and fix it onto the dural surface using a side cell and the fibrin glue. And sometimes we noticed we encountered the difficult cases vertebral artery involved types of trigeminal neuralgia. So in this case, we mobilized the vertebral artery from the level of the facial nerve, and once again we use the fibrin glue soaked the taco seal to fix it onto the dural surface, and also push downward, push in the caudal direction the vertebral artery, and making a space between the trigeminal nerve and the vertebral artery. And this is the 6 months post-operative images. So still the decompression is complete and the patient is free from the neuralgia. It's another case. It's a very tough case, and in this case, the vertebral arteries, vertebral basilar arteries are more atherosclerotic, so like a very wide atherosclerotic wall. So we decide it's very it's very dangerous to mobilize these arteries. It may cause some vascular adverse events. So we decided we just mobilize this ICA. It's pushing a medial side, and also this is the abducens nerve. So we also care for abducens nerve palsy by mobilizing these vessels. So we gently pushed ICA into the medial side using PTFE cushions. Okay. Now this is another case. So this case is the venous compression type. So transverse pontine vein and the several vessels enveloping enveloping or compressing the trigeminal nerve. So first we dissect these vessels from the trigeminal nerve, and we decide coagulating and cut the trigeminal pontine vein. We also show some video the similar cases. trigeminal pontine vein here and compressing the trigeminal nerve. So we gently coagulate and cut. Okay, just not to coagulate the trigeminal nerve. So and after dissection and a thorough dissection, release the adhesion from the venous structure of the trigeminal nerve. Okay. And the final case of the trigeminal neuralgia is the trigeminal neuralgia due to petroclival meningioma. And in such cases, we sometimes notice the tumor compress the nerve directly, or tumor compress the artery, and the artery also compresses the trigeminal neuralgia, trigeminal nerve. So in this case, we first dissect the supraepithelial vein and tumor behind the venous system. So to have more better exposure, we cut the dura over the suprameatal tubercle. So and after then, we drilled the suprameatal tubercle using a 2 mm diamond bar, and we confirmed the trigeminal nerve, and we also cut the part of the tentorium surface and checking the structure behind the tentorium and coagulate the attachment of the tumor, and there's a fourth nerve, and coagulating these tumors. The concept of this, the aim of this operation in this case is a decompression of the trigeminal nerve rather than complete removal of the tumor. So we focused on the decompression of the trigeminal nerve using the partial removal of the tumor, and after continuing the tumor removal, we can confirm the superior cerebellar artery after taking this part of the tumor. I think this is a trigeminal nerve, and removing the tumor. And here's the SCA. So we mobilize the SCA from the root entry zone of the trigeminal nerve, and once again this artery is mobilized, and fix it using a small sling of a PTFE after this. Okay. Yeah, this is going to be the final part. So we fix this SCA to the tentorial surface. So patient have the pain relief after the surgery, and patients undergo to the SRT for the remnant of the meningioma. So here is the outcome of the relief of trigeminal neuralgia. So roughly about 80 to 90% patient have completely relief of trigeminal neuralgia after the surgery, and some cases has a recurrence of the neuralgia, especially in the vertebral artery related cases, and also some cases of the SCA compressed cases. And there are several complications. Fortunately, these are asymptomatic, but there are 3 cases with a small cerebral infarct and abducent nerve palsy, which is a transient, but it lasts about 2 or 3 months. And subdural hematoma, all of them are asymptomatic. And some patient had one patient had a cervical spondylosis. It may be related with the head rotation, I think. Okay, so let me finish my presentation speaking about a glossopharyngeal neuralgia. So we just only have a very small number of the glossopharyngeal neuralgia cases. The most common compressing arteries are pica, vertebral artery, and I think some perforating artery may cause the glossopharyngeal neuralgia, because the glossopharyngeal neuralgia is a very tiny nerve. So in this case, I think this pica, also this perforating artery also needs to be mobilized. So after this dissection, we pull this pica and mobilize this perforating artery from the root entry zone of the glossopharyngeal nerve. So we made a classification like just a main pica ICO vertebral artery compression. In some cases, perforating artery may be involved, and some cases only tiny perforating artery cause neuralgia. So we have to be very carefully investigate the root entry zone of the glossopharyngeal neuralgia. In such cases, probably additional rhizotomy may not be needed. Rhizotomy is just only needed for the no truly no vascular compression cases, I think. Okay, so fortunately, glossopharyngeal neuralgia outcome is very good so far, even in the long-term cases. Okay, so just briefly describe about the issue of the pneumocephalus related to the supine positioning. So the supine positioning easily release the CSF, and probably excessive CSF release may occur due to this positioning. So to minimize these problems, we rotate the patient toward the contralateral side and heads down, and irrigate and fill the space with artificial CSF or just a saline just the end of the operation, which can minimize this problem. Okay, so this is going to be my the conclusion. So we've tried exoscope so far, probably 4 to 5 years, and the impression it can provide a clear 3D operative video, and it's very good enough to perform microvascular decompression. And exoscope microvascular decompression outcome is not inferior to operative microscope surgery so far, I think, we believe. And the team may need to arrange the operative layout to maximize the benefit of the exoscope system. And a supine position may help the gravity retraction, and may cause excessive CSF drainage. So just the end of the surgery, we have to be careful for minimize the risk of pneumocephalus and also gravity related retraction. Okay. I'd like to acknowledge my colleagues. There are many resident and young fellows involved in this project, and also like to thank Professor Koichi Wasaki and Akinori Kondo, those are mentor of our team. Thank you very much for your attention.
Professor Hiroki Toda, thank you very much for this very excellent talk and this great videos. It was very impressive. Thank you very much. Well, when I just heard your lecture, first of all, I was a little bit surprised that you have a large number of hemifacial spasm and a lower number of trigeminal neuralgia. In the European population, it's the opposite relation. We have much more trigeminal neuralgias and few hemifacial spasm. Can you comment this?
Yes. So, well, I think probably Eastern Asian population might have some little different composition of the posterior fossa, I think. So Eastern Asian people has like a more not the dolicho. So the cranial is a more like a how to say. So the shape of the cranium is a little different, I think, and it may cause some little difference on the stress on the trigeminal or facial. So Eastern Asian people suffers more hemifacial spasm. Yeah, that's some population study exists, I believe.
I enjoyed very much your positioning. I also did the surgery of microvascular decompressions in the beginning in semi-sitting position and prone position, but I ended up with supine position. I don't even lift the shoulder, and I just rotate the head for 45 degrees to the opposite side, and it works quite well. Even I do it with a microscope, and I can manage it quite well with a microscope. But I think it's much easier to do it in the supine position and that just rapid all the procedure around. This was very nice. Then I enjoyed, and I think this is really a key point of the surgery, dissecting the arrowhead membranes. So if you dissect more and more and more, you get more liberty to move around the arteries, and maybe sometimes only just opening the arrowhead sheets, it will decompress by itself the nerves. So this was very nice. I just you also show with the trigeminal neuralgia, you could save very nicely the veins over there, the petrosus superior vein, and I think this is also important. Maybe you can comment this, how important it is to save the veins over there.
Yeah. So based on the community, kind of community-based experiences, I think. So Japanese society consider the preserving of the superior petrosus vein is the very important. Well, I think that to preserve that venous system, just cutting the arachnoid sleeve on the superior petrosus vein. So just starting cutting the arachnoid around the superior petrosus vein is very make it easy for further dissection of the venous system, I think. So yeah, that's the way I do for venous preservation.
Great. I have a lot of other questions. There's another question from the audience. Somebody is just asking about your experience about radio frequency thermocoagulation and also the gamma knife surgery. What do you think about it?
Yeah, so as the microvascular decompressionist for myself, we prefer the MVD rather than the gamma knife because but some elderly patient who cannot tolerate to the surgery, I think the gamma knife or radio frequency is a good option for them, and also the patient who don't have any vascular compression, even for the venous compression, if they don't have any arterial or venous compression, I think the patient needs to rely on the rhizotomy or gamma knife surgery. So needs to be balanced.
Nowadays the MRIs, they are so good. They will show us, I think, all the time if there is a compression or not. There are still a lot of neurosurgeons, they say, where you never know what is going to happen. You just should go in. My personal opinion is if I don't see anything, I just do the thermal lesion or something like that, but I don't go in if I don't see anything on the very good MRIs. What is your opinion on that?
Yeah. So, well, I think you have much more experience than me. So, I think we might have some cases, the MRI negative, but operative positive neurovascular compression cases, I think, especially for the very tiny vascular causing neuralgia cases. So, like a TCAs can be very tiny, but it circle around the trigeminal nerve, and it may cause a neuralgia. So, if we suspect that any suspect of the small vessel related neuralgia, maybe we can offer the microvascular decompression as a second or maybe first or second option for them, I think.
I think there was a question. Yes, please.
Yeah. Sometimes you see culprit vessel behind the retromeatal ridge. So do you use endoscope for this?
Yeah. Well, that's our next step. So our team is not a fully or like a even endoscopic system. So we basically rely on the exoscope, but yeah, we are learning to do endoscope because we don't have this. We have endoscopists here, so yeah.
Yes, if I may say from comments, just from my point of view, I think for trigeminal neuralgia, it's quite easy to see. But if you go to hemifacial spasm, you just have to go around. It's a little bit more difficult, the dissection, because you have to go around the corner or you have to just retract a little bit more in those cases.
Yes.
I have another.
Yes.
Excuse me, please.
Sometime in trigeminal neuralgia MVD, we see facial nerve palsy post-operatively. So, what is your experience and
So
post
facial nerve
MVD? Facial nerve palsy post MVD for trigeminal neuralgia. I've seen 2-3 cases. So, what is your experience?
Yeah. So, well, fortunately, so facial nerve palsy.
Yes.
We don't have a facial nerve palsy in the trigeminal nerve case.
Okay.
So, yeah. Basically, we utilize the subtentorial approach, and also we use the so kind of combined like a subtentorial approach and along the petrosal. But we utilize the horizontal fissure dissection, not to pull the facial nerve.
Okay.
So maybe that helps us to minimize the risk of the facial nerve palsy, I think.
So I consult the literature. Literature says because of brainstem infarct, sometimes you may have facial nerve palsy, but it improves with time.
Yeah. Well, I believe it improves time, even it occurs, but yeah. So yes, maybe. Well, I might have some such cases maybe next week.
Okay.
Okay. So yeah, I'll be careful for it.
You just talked about the glossopharyngeal neuralgia. That's well, really a tiny nerve, and sometimes you have to do a rhizotomy if you don't find anything. So you just cut it. What do you experience any deficits in those patients?
Well, fortunately, so we basically do dissection only.
Okay.
Yeah.
But I know I saw a lot of American talks from the States. They just sometimes they cut it, and no, they just say no deficits afterwards. I just wanted to hear your opinion. Another topic what is very much discussed if you have multiple sclerosis and you have a vessel which is compressing the nerve. You go in for a microvascular decompression if you just see some white spots intrapontine in the tract of the trigeminal nerve root. You still do with multiple sclerosis, you do then a microvascular decompression, or you try to do it?
Well, there's a literature evidence also exists. I'm assuming you already know it. And we don't do multiple sclerosis related to trigeminal neuralgia cases. Yeah. Well, literature said, as you may know, if there's a vascular compression, the MVD may be effective for those patients, but so far I don't offer the MVD for those patients. Yeah.
Yes, also we are very reluctant to do it because the results are not good. Also, you can see it in the literature, and sometimes we may think about if there really a strong and very heavy compression of the trigeminal nerve, then we might discuss it. But usually we avoid to do it in multiple sclerosis.
I might think about it, but so far I don't have such patient. But yeah.
If you have a recurrence of a trigeminal neuralgia, what you do? You go back or you do a thermal lesion?
Yeah. So we are now trying the neural combing, like neurolysis.
Okay.
But so far the effect is quite limited, I think. I mean, just in my series. So we also offer the gamma knife or other options. But if they agree, we offer the neurolysis. So just like a combing, like put the spatula in a that is tiny spatula, like a combing, combing the hair, like a combing the nerve. Yeah.
I also want to ask something. You had very few complications, and for trigeminal neuralgia, for instance, you had not even one case of CSF fistula. How do you close the dura? How do you get it watertight closure in
Yeah.
all cases?
So, okay. So first, we very tightly pack the master layer cells using bone wax. This is number one. So after the craniotomy, we wax, very wax, and the closure is the distance between the stitches like 0.7 millimeter or 0.8 millimeter, so like less than 1 millimeter. So, but it's not so tight. And we also apply the fibrin glue or fibrin glue soaked the collagen sheet. Right now we're using the Duragen. Yeah.
Do you ever use a lumbar drain?
Lamadre, no.
Oh, okay.
Yeah.
Okay. Thank you very much.
Thank you
My
very much.
last question is still about you didn't talk about vestibular paroxysmal. And sometimes you have this vestibular paroxysm, and it's very difficult. The surgery is easy because it's more posterior than it's
Okay.
for hemifacial spasm. But it's so difficult to know if it's coming from the right or from the left side. How do you had some cases, or how did you manage it, and how
Well,
did you
unfortunately, I don't
decide
have
the
a.
side?
Yeah, well, my senior, so Professor Kondo, have several experiences. That's what I heard. But for myself, I don't have vestibular paroxysmal cases. No, so far. So, yeah, I've learned the important question, important issues from your comment. Thank you very much.
Yeah, the problem is to know if it's from the right side or from the left side, because very often you have on both
I
sides
see.
some vessel nerve contact. But if you have a tinnitus during your vestibular paroxysm, then you know from which side it's coming from.
Oh, I
Well,
see.
it was really great. I enjoyed it very much.
Oh, thank
I
you
don't
very
know if
much.
there's
I learned
some
a
other
lot.
questions from our shares, from the co-shares.
Yes,
If
of
not,
course, we have.
yes, yes, please.
Actually, first of all, let me thank Prof. Hiroki Toda for this very wonderful lecture, and
Oh, thank you.
we learned a lot today from your wonderful videos and beautiful demonstration of techniques. There are three questions. First one is like, do you monitor the AMR in HFS, because disappearance of AMR is correlated with long-term disappearance of the spasms. So have you any experience regarding this? And the second question is regarding that interfascicular isolysis that you talked about. So in what percent of glossopharyngeal neuralgia in your experience have you done it? Because I remember once I was a fellow with Professor Yoko Kato, and we had done an interfascicular isolysis for trigeminal neuralgia. And the third one is regarding the incidence of hearing loss after microvascular decompression. So what is it in your series?
Okay. So your first question is your first question was
AMR.
IMR, yeah. So we for simple case we don't use the AMR. Like the complex case like multiple compression or like cysternal compression, the root excision and cysternal compression cases, we use the AMR, but not regularly using the AMR. The reason is our results so far is not consistent for the AMR, because we noticed the AMR disappeared, but patient have like an immediate recurrence, but we know the spasm goes away within the first few months in most cases. So we don't rely on the AMR so far. Okay. And your second question is
Talked about interfascicular isolysis.
Yeah,
The
neuritis. So
combing.
yeah, so we apply this technique just only for recurrent cases of the trigeminal neuralgia, and just for glossopharyngeal neuralgia, glossopharyngeal is very tiny nerve, and we might rub it, rub the nerve during the procedure, but not intent. We don't intend the neuritis for the glossopharyngeal neuralgia. So. We might consider if the patient have the recurrence of the glossopharyngeal neuralgia cases, but so far we don't have a chance to do such technique in those glossopharyngeal neuralgia cases. And the last question is the auditory dysfunction.
Hearing loss.
Yeah. So we have only one case of auditory nerve dysfunction. So we just to minimize such risk, we intensively repeat the monitoring. So like every 2 to 3 minutes, we check the ABR, brainstem reflex, and just a slight extension of the fifth nerve, like a latency is delayed like 0.5 or 6 millisecond. We check the dissection, we check the operative field, and if we think we need more dissection to minimize the retraction, we add such dissection. And so that's the way we try to minimize the auditory complication. Yeah.
There's another question from Ben Young, please.
Yes, and thank you, Professor Toda, for your great
Thank you.
lecture and really interesting. And I want to ask about I want to ask two questions. And the first question is about the use of the lateral spread, the monitoring, because
Yeah.
sometimes I find it is sometimes hard to interpret. For example, like if the after your decompression, so let's say the lateral spread disappear, say at 5 MA, and then somehow your neurophysiologist increase the amplitude, for example, like 10 MA, and then it reappear. So by your surgery, you already see that the vessel is separated from the nerve, but still there is some lateral spread. So would you stop or would you pack more, for example, a Telfer in this regard? And it's my first question, like how to interpret the lateral spread. And my second question is about I encountered a case with hemifacial spasm due to the VA compression, but somehow the patients also complain some shoulder triggering of the same side, and on the scan the VA do in contact with the lower cranial nerves. So is it necessary? Do you encounter this situation, and is it necessary to also decompress the lower cranial nerve in this situation?
Okay.
Thank you so much.
Okay. So well, we apply more than 10 milliamp to do LSR. Yeah, and, like 15 or maybe near 20.
Near 20.
Okay.
So if it's more than 15, it disappear, then it's safe.
Yeah. So you mentioned that you pack the Teflon or something between the nerve. So between the nerve and the artery. That's what I'm understanding. But well, we try to mobilize the artery and no packing, basically, like mobilized and no just making space between the artery and the nerve. So well. We might consider packing, but basically we don't insert anything between the nerve and the artery. So maybe this approach is also a little different. And I agree that if you increase the amplitude, responses persist. And actually, some patients needs time to have a complete resolution of hemifacial spasm. We don't understand the exact mechanism of the physiology. So that's my the reply for your comment.
I see.
Yeah. And the second case, you said, so like it's like a painful tick convulsive, but it's not a trigeminal neuralgia. It's like a ghost-like neuralgia. That's a
Yeah, it's
right?
hemifacial spasm. Actually, the patient have a very bad hemifacial spasm.
Spasm plus glossopharyngeal neuralgia. Is that the way, or maybe
Uh,
hemifacial spasm plus
no,
spasm and
yeah.
intermediate nerve like a neuralgia, like
No, he had a hemifacial spasm, but he also had a twitching of the shoulders.
oh, okay.
Yeah, but the VA
Shoulder.
is quite this in contact with the lower cranial nerves as well. So it compress it in touch with the seventh, eighth compass, but also at the lower cranial nerve. But
Okay.
I'm just asking, is it necessary decompress the lower cranial nerve as well? Any experience?
Well, I don't have a similar cases so far. So, well, I consider about like as you said, painful tick convulsive like a fifth and a seventh simultaneous compression, and the same case maybe occur in the between the facial and the other lower cranial nerve. Maybe possible, but I'm not sure it's going to be the shoulder pain. So, yeah, well, I cannot answer your question.
I see. Thank you so much.
Well, thank you.
Any questions from Liu?
Yes, I would also ask you something. If you have a trigeminal neuralgia and you do the microvascular decompression, almost all just they wake up from the anesthesia and no pain anymore. If you have a hemifacial spasm, there's a big group. Well, there are some they will finish immediately with the hemifacial spasm, but there's a big group. They still have the hemifacial spasm, and it takes about months or half a year that's a hemifacial spasm stop. What is the difference? Why is the healing of the hemifacial spasm so different to the trigeminal neuralgia?
That's my
Have an
lifelong
explanation.
question. Yeah, that's my lifelong question. And maybe some sodium channel or any other nerve channel. I mean, ion channel characteristics differ. I think so. Carbamazepine works for the hemifacial, the trigeminal neuralgia, but carbamazepine not always work for the hemifacial. Actually, does not work at all for the hemifacial spasm. That's my understanding. So, well, I don't want to. I want to attack that question. It's my kind of lifelong question. Yeah. Thank
Any
you.
Yeah,
questions
but
from Liu?
nobody knows it really, and but I do not agree with you that carbamazepine doesn't work at all in hemifacial spasm.
Oh, okay,
So
sorry. Yeah.
we have this.
Sometimes works,
We have this also as a first line treatment as well. So we give carbamazepine for hemifacial spasm as well.
Yeah. I
Well,
also sometimes try the phenytoin. I like. Yeah. Sorry.
Yes,
May I
Liu?
ask one question, Professor. First of all, I would like to thank Professor Toda, because I have been doing my fellowship with Professor Toda for the past 6 months, almost 6 months, and I learned a lot from his technique. Just one thing that I observed is in all cases you did a quite extensive arynoid dissection, and some cases I saw have very thick arynoid. And I find that this wide arynoid dissection not only help in mobilizing the cerebellum, so no retraction, and also mobilizing all the vessels surrounding it and easy for you to transposition it. But in terms of pathophysiology, do you find that all these arynoid are the one who enhance the effect of a microvascular compression in those cases, and especially due to compartmentalized CSF system, where, by the way, when you do the surgery, open up the system, that's why you have very low complication and a very high success rate. Would that be accountable for that? Thank you, Professor.
Oh, thank you. Yeah. Well, basically, the microvascular decompression surgery is the cutting the arachnoid. I think that's it. So maybe that's why our team focus on the safe dissection. But I'm not sure that effects on the electrophysiological or the physiological effect on the peripheral nerve. I mean cranial nerve. So yeah. With the previous question, that's going to be our team or our group, our surgeons are involved in this MVD. Yeah, thank you very much.
Thank you for your excellent talk.
Thank you very much. We can go back to Prof. Keller for his concluding remarks.
Yes. Well, I thank you very much for this very instructive talk. I think we learned very much. We had a wonderful discussion, and I think we just got all some ideas what we have to think about if we go in. And so thank you very much. I think it was very instructive and was a very good session. Thank you so much.
Thank you very much. Yeah, thank you for the great discussion
Yeah.
and many comments. I appreciate a lot. Yeah.
Well,
now I pass over.
Right. Thank you very much. It was indeed very wonderful session. And I would like to inform your viewers that this has been broadcasted on WeChat, YouTube and Zoom. And thanks to Professor Shubin, we have around 1,300 people live today who has joined this webinar. So thank you very much. Now we'll move on to the second session. Second session is pretty interesting. We are all looking forward what is about the body position therapy. And I would like to hand this podium over to Prof. V.D. Sinha to take over the second session.
First, I want to thank Professor Kato, Dr. Raja, and Dr. Boone for inviting me for this very prestigious webinar. And welcome, Dr. View, for this webinar. And just I want to share, first time we met in June 2021 during our 2 days webinar meeting. You were a speaker that time in one of our webinar. You know that chronic subdural hematoma is a very important and common problem in neurosurgical practice. After surgery, recurrence is another problem in the chronic subdural hematoma. We try embolization or we can try the pharmacotherapy, but it is still controversial. So body position for prevention of recurrence is another mode of therapy for recurrence of the chronic subdural hematoma, and lot of literature is there. And Dr. View, I know that it will be very interesting, your lecture, for sharing your knowledge to our audience to manage this patient after recurrence in chronic subdural hematoma. So welcome, Dr. View, and he will speak on the body position therapy to increase ICP in chronic subdural hematoma. Dr. View, please. You can share your screen.
Thank you, Chairman Sinha and Professor Raja and Keller. Great honor to be here to communication about chronic subdural hematoma. Thank you very much. My topic is the body position therapy to increase intracranial pressure for chronic subdural hematoma. As we know, chronic subdural is very common in our neurosurgical department, but we have very surprising and phenomena. The recurrence rate after chronic subdural surgery, the recurrence rate in China is about 5 to 6%. But we can, from the literature, can even higher more than 20 to 33% in the USA and the European country. This is very strange. It's impossible to have a difference in the surgical technique. Why has it happened so big a difference? And the second, middle meningeal artery embolism for chronic subdural hematoma. We have 3 papers released in New England last year. Emboli, STEM, and MAGIC. The 2 clinical trials showed middle meningeal artery embolization is very helpful, but the MAGIC means no obvious difference between 2 groups. Why have so different for 3 clinical trials? We believe the 3 clinical trials are very excellent clinical trials. So the 2 phenomena have the common reason. This mesosome, large dose use we found have fewer favorable outcome and more adverse events than placebo. And this paper have released in the New England, and compared to the surgery, this methadone was associated with the more complication and the great likelihood later surgery. So this methadone not advocated in many countries. Obviously, the surgery is the milestone for chronic subdural hepatoma, but we know now the global prevalence of CSDH is about 13% per 100,000 people or age, but much higher in elder patients. Now, the CSDH is predominantly is the disease of the elderly, and increasingly prevalent with the population aging. So chronic subdural hematoma surgery is the top surgery for TBI in numbers in many hospitals, like in our hospital. But we know surgery is suitable for patients who present with a large hematoma, and the obvious symptom and the urgent situation without surgical contraindications. But for surgery, we still have 5 to 63% recurrence rates. This figure showed the chronological change in age distribution. The peak age of incidence of the chronic subdural is shifted to much older people. Yeah, and for different surgery, this figure compared the mortality and the morbidity and the cure rate and the recurrence rates with the different surgical method. We found they are all have more than 10% recurrence rate. This is very high for these patients. And these patients have a cognitive subdural, but we find very huge allochnoid cyst. Obviously, the chronic subdural hepatoma have greatly related with the allochnoid cyst rupture. Yeah, so maybe the cyst rupture is the reason of the chronic subdural hematoma development. And we also find that this child compared the recurrent rate in different body posture. Group A, the patients keep in supine position 3 days after operation. The group B have a sitting position in bed with the head of bed elevated to 30 to 40 degrees. But 3 months later, we have different recurrence rate. In the group A, the recurrence rate is 2.3%. But group B, with the head of the bed elevated to 30 to 40 degrees, this body posture is usually used in our neurosurgical surgery. But the group B have 19% recurrence, obviously much higher than the group A. Why? Now we from these figures, this paper released in the Nature, find the brain chart for the human lifespan with the aging and become older people. Our brain volume, including the gray matter volume, white matter volume, total brain volume, becomes smaller and smaller. But clinical cavity is stable. So with the brain volume becomes smaller, the pressure in the cranial cavity, especially including the subdural space, the pressure decreased. So this is mostly happened in the elder people, not in the young people. And so this paper in the New England find the spontaneous intracranial hypertension phenomena. We can show the chronic subdural. So chronic subdural can happen in the intracranial hypertension. Now the CF leakage usually is the reason of the cranial hypertension. This bilateral chronic subdural hematoma patients, the patient associated with the intracranial hypertension, this patient treated with the epidural blood patch and burhole, the patient recovered very well. And so for our neurosurgery, we sometimes we were in a dilemma. After surgery, the patient recurrence happened is a dilemma. But some chronic subdural patients without obvious symptom, do we select surgery or observation? If we select observation, do we have good choice, good method to treat them well? For the mildly symptomatic chronic subdural hematoma without life danger and super older people, such as more than 19 years old, with severely comorbidities, or some patients cannot tolerate surgery or reject surgery. Do we have a choice, have a method to treat them well? So a 12 study, the paper released, the German neurology showed can slightly better than the control group into the hematoma volume reduction and conversion to surgery. And a 12 study plus the dexamethasone are also believe this paper showed can have complete recovery in neurological function at 5 weeks and achieve about 83%, and compared to the atorvastatin only in about 22%, is much better. This dexamethasone here is the minor dose, not the large dose use. But we suppose intracranial hypertension related with the chronic subdural hematoma development and the recurrence, because the brain atrophy in the elderly patients with the progressively decrease in the brain tissue volume, and the intracranial pressure decreased in the subdural space will be happened. And as we know, chronic subdural hematoma recurrence was associated with the decreased brain volume post-operative pneumocephalus. Chronic subdural also associated with the subdural hygroma, overdraining of the cerebral spinal fluid, such as the VB shunt overdrain, and the rupture of the alaconoid cyst. Yeah, and the elevation of the head after surgery. So we have a posture therapy, turn the position first, and turn the head to the hematoma side, and to the countryside is prohibited. This is case in our within 8 years to my clinic. The first line is the before posture therapy. The second line is the after posture therapy, and most of the cases recover very well. So we decided have a clinical trial, we have two groups. One group we select according to the literature, the atorvastatin plus dexamethasone appears is a good method. So we select the atorvastatin plus the dexamethasone as a control group, and the treatment group with the body position plus the drug used, atorvastatin plus the dexamethasone. We 116 patients enrolled, and they were randomized to the treatment group and the control group, and the no obvious difference for the two group, the baseline characters, and we find the primary outcome is the change of the hematoma volume. The 3 months later, averaged 81 milliliters hematoma volume reduction in the treatment group, and for the control group, average was 51 milliliters. They obviously have distinct difference between two groups. For the secondary outcome, we have the surgery conversion rate. Only 3 patients among in the 55 patients transferred to surgery. Other patients, we follow up 1 year, all recover very well. And at 11 patients among the 51, about 21% transferred to surgery. They have a distinct difference between two groups. And we find that midline shift changes in the 1 month, 2 months, 3 months, the two groups that have obviously difference. Well, the treat group have obviously better than the control group. This is the figure shows the hematoma changes is much better in the treatment group. So see here we can see some cases. And this female patient, 74 years old, and the patients have hematoma more than 100 liters. The patients obviously need surgery, but the female patients reject. Confirm reject the surgery. So the patient enrolled and the patient randomized to the treatment group. So this is before the treatment, the body posture. After body posture, turn the body position and turn the left side, and the patient 3 months later, the patient midline shift recover totally, and obviously absorption. Now this is a 58 years old man, the woman, before body posture, and 27 days later, totally recover. And this patient is 74 years old, before body posture, and 2 months later and 3 months later. 3 months later, totally recover. And then this patient is 81 years old. This patient, the first to my clinic with the wheel steel. Cannot walk, cannot get up. The 3 months after body posture treatment, the patients recover very well and can walk very steadily. So we another child. We monitored the pressure under the subdural space after surgery. This is 67 years old. We open the dura and put the intracranial pressure probe in the subdural space. This is the initial pressure, about 8, is normal, not high, and after we close the scalp, we shoot the scalp. This is the pressure is 1 mmHg. Well, this is CT scan immediately after the surgery, And this is the wonder to the world. We immediately monitored the ICP. Did the patient lying flat? Is the -1 mmHg, and so we raised the lower limb trend position 5 minutes. ICP is 0, and the second day, the ICP increased to 19, 20. Yeah, so this is the position. So now for the country group, we find that this is just we sutured the scalp. Yeah, the ICP is -2 mmHg, and the day to come back to the wall, the day of the birth hole is -3, and this first day the CT scan, and 2 days after birth hole drainage, the ICP is still -3, and we have this case. This case is do 2 operations in other hospital and not enrolled our clinical trial. The patient is 70 years old. He first this before operation, and this is the second day have the birth drainage, but the 9 days later, the patient chronic subdural hematoma recurrence happened. So the patient, 10 days after the first birth hole, the patient is this time selected craniotomy. This is the picture, and this immediately after surgery CT scan is here. Very unlucky. The patient surgery after the first birth hole and 5 days after second surgery, the patient, the second recurrence, the patient lose consciousness and incontinence, brain hernias happened. So the patient come to me to me and consults me. So, but we have, because we have no beds in our hospital, so I transfer the patient to our rehabilitation hospital. So the patient accept the body posture, just hold the posture and turn the position and turn the head to the left side strictly, and the 20 days later, the midline and recover, and the subdural hematoma reduction very obviously. Now the patient recovered very well. Now we come back to the 3 paper in the New England for the magic MIT, and so 360 and in the embolism group, and the country group is 362. There's no obviously difference for the recurrence rate. Is 60.6% and 90.9%. We can this flow chart. For also all these patients, after embolization, immediately the patient accept the birth hole drainage. So the country group and treatment group have no obviously in hospital stay, means no obviously stay in bed time during the hospital. But embolism, we can see the embolism group and the country group. The randomization occurred after the neurosurgeon determined that the surgery was indicated, or up to 32 hours after surgery were completed. The patients were randomized assigned to the treatment group could undergo surgery either before or after embolization procedure. Middle meningeal artery embolization took place within 48 hours after randomization. This just means, but for the country group without embolization, they not in hospital, they not stay in bed. So much so they stay back better time much longer than in the control group. So the patient have different recurrence. For treatment is 4.3 group and the control group 70 group, the significant difference. And STEM trial, we find STEM trial for the no surgery group, yeah, treatment group, embolism, they in hospital, no surgery, the control group, no in hospital, no in hospital stay in bed. So obviously have obvious difference in bed time, in hospital time. So we believe the bed time and is the difference for 3 clinical trial and for low recurrence rate in China, and because China is much longer stay in hospital, longer than in USA and Europe. Yeah. So they have a big difference the recurrence rate. So we have a clinical trial. We have a clinical trial just want to know the effectiveness and safety of body posture to improve cranial pressure in preventing the post-operative recurrence for chronic subdural hepatoma. We will enroll 30 cases, and now we have 28 units hospital take part in our participate. The start time is August 2024, and the operation mode is bowel drainage routinely, and the group A treatment group is post-treatment group. They are trained position and turn the head to the hematoma side. Control group conventional body position. No body position demand. This is our flow chart. Yeah. We looking forward to the result and reporting to everyone as soon as possible. Yeah, this is the end. Thank you. Yeah, very much.
Thank you, Dr. View, for wonderful presentation and very large series of cases you did this posture to prevent the recurrence. And we know that in chronic central rural hematoma, there are a lot of treatment modality there. One burr hole, 2 burr hole, drain, keratomy, embolization, and every therapy has some degree of recurrence. So just I want to ask you, what is the height you preferred of the lower end in this patient for? How much elevation you do in the
how long?
lower, yeah, how long and how much? What is the height of the lower limb you raise to prevent the recurrence?
30 degree to
30 degree.
30 degree, yes.
Yeah.
For the recurrent rate, the child, we ask the patient to keep this position at least 6 hours a day. 6 hours a day in the discharge in the at home. Yeah.
So ever you tried the abdominal belt for this?
Yes.
Abdominal belt, because raising the lower end and combined with abdominal belt, it works better. What is your experience? Abdominal belt, abdominal binder. You raise the lower end and you put the abdominal binder both together.
We have every patient we give them the pad raise the lower limb. Yeah.
Okay.
Yes.
No, you don't use the abdominal binder, abdominal belt to raise the ICP.
No bad.
No belt.
No
Okay.
bad. just the Trenberg position and turn the hematoma side. Yes.
And you very well mentioned about the recurrence rate of the patient where head was not elevated and where head was elevated. When head was not elevated, the recurrence rate was only 2.3%. And when head was raised, recurrence rate was 19% in your series. So what is our policy? We keep the lower end elevated if during surgery brain don't come to the surface. If brain come to the surface, we don't keep lower end elevated and we keep patient head end elevated. So this is our policy.
Sorry, I don't understand what you mean.
I want to mean that in all the cases you keep the lower end elevated, lower limb in all the cases you keep lower limb elevated.
We keep the trunk position. Yeah, just as home, the relative we monitor, and we will have the diary card to recording the better time and the posture the time.
Okay, and what you do for bilateral or unilateral? Is it the same policy or different?
For the bilateral,
Yeah.
we just ask the patient to do the trend position, and not ask the right or left, then just balance, not the turn side the demand. Yeah, but the unilateral chronic subdural hematoma, the patient should keep the head to the hematoma side, but the patient can keep supine the position and the hematoma side, not the control side.
Okay, when you do the craniotomy after burr evacuation, if patient has recurrence, when you do craniotomy, large craniotomy.
For me, no craniotomy.
No craniotomy. Okay.
It's for me with the body position therapy, almost no recurrence. If we have the recurrence sign, some the trend of recurrence, we keep the body position is good. Yeah, we have many cases from other hospitals to my clinic. Yeah, and recurrence we use the body posture treat them very well. Yeah, we believe this is good, but now we need a clinical trial to prove my hypothesis. Yeah, thank you.
So when you do elevation of lower limb alone, and when you combine with pharmacotherapy, dexamethasone and atovastatin, which is better? Is it combination is better or lower limb elevation is better?
You mean the atovastatin?
Yeah.
And dexamethasone?
Yeah.
Oh, yeah. In China, atovastatin is very common use in chronic subdural. The minor dose dexamethasone, from my experience, very minor dexamethasone is not obviously harmful to the patient. Yeah, so it's very safe. We find that the dexamethasone is more effective than atorvastatin. So if the patient recurrence, minor dexamethasone can be tried. If no diabetes, so it's very, very safe. Yeah.
When we started our neurosurgery career, we were seeing chronic subdural hematoma in elderly patients. But now we see in number of cases young patient chronic subdural hematoma. What is your experience?
for the aluconoid cyst rupture, in my clinical to treatment the clinical subdural, we have one patient is enrolled the treatment group. This is a young man. He's colleague students. We use the body posture treat them. Recover totally. But the first month, the patients cannot apply my order. He still go to the hospital to the school. So the first month, no obviously reduction. So that the second month, I asked him to keep in bed much longer, no to the hospital 1 month. The patients now then recover very well totally. But I think the Berho drainage is necessary. They can recover much faster. And after Berho drainage and then keep the body position, give the body posture, maybe can recover much better and quickly.
Okay. Thank you. Any comment or question by audience?
Yes, of course. First of all, I'm really surprised by the results that you have got, because it is contrary to the different trials that have come across in the recent times. Have you heard of the Get Up trial, which is by Souza et al. From Portugal? In that, they had 104 patients in one group where they were mobilized within the first 12 hours, and the second group was given total bed rest for 48 hours, and they have published their result in the JNS about the results of 208 patients, and they have found no difference between recurrence at discharge or 1 month. Now in 2024, they came out with the long-term results of the GetUp trial at 1 year, and still they have not found any difference in recurrence between the early mobilization group within the first 12 hours and bed rest groups. And they have found out actually the functional outcome was better in the patients who were mobilized early, and the medical complications were also less in the patients who were mobilized early. So I'm really surprised about the findings of your study. Nevertheless, it is very interesting, and I would like to hear from others too. Prof. Toda Hiroki, what is your views on this?
Yeah, it's a very interesting topic, and well, actually, so right now in Japan also the embolization is available, but only for the very recurrent case, very refractory recurrent cases. So the topic on the body position is quite interesting, and so well, in my thought, body position makes some kind of venous like a hemostatic work on the hemostatic system, but not sure the so can you clarify what is the main reason for the why body position is effective for the hemostasis for the CSDH?
What? Sorry.
What is the reason for body position therapy? Like, is it some venous return or raising ICP, or what is the reason?
Venous thrombosis raise the joint population, raise the lower limb will actually very help is very helpful for the venous drain. So in our patients, no thrombosis.
So our policy is we keep only head and lower end raised when the brain don't come to surface during surgery. Otherwise, no. And we don't find any change in the recurrence in the patient who were allowed sitting or who were not allowed sitting. So we don't find any change. Dr. Raja, you already quoted the literature also. This is our view.
Right. Thank you. Ben
Mm.
Sensei, any comments from your side?
Yes. And first of all, congratulations to your results. And I do have some questions. So in the cases that you found the recurrent cases, have you thoroughly ruled out intracranial hypotension for the causes of the recurrence? Because in the sense that there is a hypotension as demonstrated by you with the pressure monitor, and then your venous elevating the leg will increase the pressure after the subdural surgery. So it means that there is still a hypotension. So in your case series of the recurrence, have you ruled out that with the, for example, a myelogram or a spinal MRI in this group of the patients? So another question is about any mobility with the related to keeping the patient for the bed rest for a long time. So say for 3 days, any increase in the thromboembolisms in the patients with this therapy?
The second question is the body keep this position longer time. Maybe the thrombosis happened. The patients that keep this position at least 6 hours. But the patients we ask them to keep keep movement after meal. Yeah, within 2 hours, don't keep this position, and after the digest well, no residual in the stomach. Can do it. So the patient, we as a patient keep and can raise and can work, can keep move every day. We keep at least 6 8 hours a day. So that not all time in bed. Yeah. So
I see.
So
there is a time allowed for them to mobilize in your
yes.
case. So I see. Thank you. And how about the in your case series of the recurrence, have you ruled out the causes of the intracranial hypotension?
Lots the intracranial hypertension patients. We will lose out the VP shunt over adrenaline patients. Yeah, if the patient the hematomas because of the VP shunt of adrenaline, we just this patient is not needed for birth adrenaline. The patient just raise the VP shunt level. Yeah, to the highest, and the patient we can observe. We no high ICP symptom. If the patient tolerate the no severe headache with the vomiting, yeah, the patient, yeah, which is raise the VP shunt valve level. Most of the patient can recover. Yeah. So this patient we cannot enroll our in our the recurrent clinical trial. We don't enroll the allogeneic cyst rupture. This patient the patients more than 6-year-old patient, elder patient, younger patient will not enrolled in our trial.
I see. Okay, so thank you so much and congratulations.
Thank you very much. We can go back to our chair for his concluding remarks.
Thank you very much.
Thank you, Dr. View, and for your excellent lecture. And definitely, we will follow your protocol or guidelines in the patient who had recurrence, and definitely this will share your share of knowledge will help lot of patients. And thank you very much again for your excellent lecture. And see you sometime.
Thank you, Chairman Xinhai. Yeah, thank you.
Yes.
Well, thank you very much. I think it has been a very interesting talk, and we are waiting for your publication to come out and hear the comments of other leading neurosurgeons as well. Now it's time I'll wind this podium, and I'll do this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Toda Hiroki and Professor Wu Shuehai, as well as the chairs, Prof. Uwe Keller and Prof. Virendra Sinha, for the time and support for the ACNS webinars. A very special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 1,300 people who have joined us live today. And special thanks to my co-host Libun Singh for joining me today, and also Ben for taking out his time. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.